Let me just read a synopsis of what this is about so we're all on the same page. Ketamine has sometimes been called the date rape drug because its sedative properties have enabled sexual assaults, but a groundbreaking study suggests it can also reduce symptoms of depression. Psychedelic drugs such as psilocybin and LSD can trigger a schizophrenic episode, but their potential to treat addiction, control PTSD, and prepare terminally ill patients for death is intriguing. And while marijuana is a controlled substance under federal law, 33 states allow it to be sold for medical uses, and 11 say it's okay for recreation. Researchers are taking a fresh look at the treatment values of drugs with a reputation for danger and making some surprising discoveries, and that's what we're going to talk about here. And to talk about this is my panel of experts. So let's start at the end with Dennis Charney. He's the Ann and Joel Ehrenkrantz Dean, Icahn School of Medicine at Mount Sinai, the President for Academic Affairs of Mount Sinai Health Systems. So Dennis, thank you very much. In the middle, Mallory Laughlin. She's research scientist and principal investigator, VA San Diego Healthcare System, and assistant professor of psychiatry, School of Medicine, the UCSD, University of California, San Diego. And next to me is Rick Doblin. He's the founder and executive director, Multidisciplinary Association for Psychedelic Studies, and a PhD from the Kennedy School of Government at Harvard. So let me ask you this first question. Is there such a thing as a bad drug? Or are we looking at it the wrong way?
I think we're completely looking at it the wrong way, because the fundamental fallacy, I think, of the war on drugs is that we invest these properties in the drugs, and what we're omitting is it's the relationship that we have with the drugs that determines whether they're valuable or not. And the best example of this is thalidomide, which was used for morning sickness, caused a lot of birth defects, and the only person at the FDA that ever won the Presidential Medal of Honor was the woman Frances Kelsey that blocked thalidomide from becoming a medicine in the US. But thalidomide is now a medicine approved by the FDA for cancer and leprosy. So there is no such thing as a good drug or a bad drug. It's how we use it.
It's how the drug's being used. Ketamine is the prime example. And Dennis, this is your area of expertise. Explain a little bit about what's been going on with ketamine over the last few decades, or at least the last few years.
Okay. So we did the first study with ketamine, showing that it was an antidepressant. And it was based on the idea that a neurotransmitter called glutamate was involved in depression, the causes of depression. So we decided to study ketamine. And somewhat to our surprise, but not completely, we found that low doses of ketamine produced a very rapid antidepressant effect in some patients within a few hours. And these were patients who had been depressed for many years. Now, there was concern about ketamine because it has been a drug of abuse, Special K, but the way the drug has been used thus far, it's used very carefully. You know, as you know, it's an approved drug now based on studies done by Janssen. And given that it's approved for treatment-resistant depression, which affects about 5 to 10 million people in the United States, treatment-resistant depression is a lethal disease, and ketamine looks like it could save millions of lives, but it's got to be used in the right way. And you know, similar to what Rick said, if you use it in the wrong way, you abuse it, it's a problem. You use it in the right way, it saves lives.
And Mallory, the VA is doing a lot of work, and the groundbreaking work in this area with different drugs because of...
a lot?
Yeah. But they're doing groundbreaking work because of the veterans' issues they have, PTSD, depression, suicide, those types of things. Is this coming into play a lot with the drugs that we used to think, okay, those are off limits, those are something we should use, but now it's looking like they might be legitimate?
Right. I mean, it's tough to say. VA is a big system. There's a lot of researchers who obviously our primary focus, a lot of my colleagues and I, is on treating PTSD. That's my background. That's my focus. And there certainly appears to be an openness of other researchers like myself in investigating novel compounds that can attempt to remedy these disorders that are massively impacting veterans' lives, and others, not even just veterans. So I have the first VA-funded clinical trial of a cannabinoid, CBD, for PTSD that we're running right now at the VA San Diego, so that's huge. But it's one study that's going on right now within the VA healthcare system, at least that I'm aware of. But, I mean, the fact that that made it through, so how these types of grants get funded in something like the VA system is you You write a grant, you pitch basically like you would to NIH or anywhere else. They send it out to a group of your peers who study the same thing, and they rate it, whether or not there is scientific merit. And then it comes back with a rating, and they determine, okay, we have this much funding, and here's the numbers. Mine was funded on the first round. That rarely happens, and that only happened because of the high score of other researchers considering this having high scientific merit. So I do think there's an openness. There's definitely a change occurring. I don't know how fast that change is occurring,
well,
but it's
to
occurring.
talk about how fast it is, since 1990, we've been offering money to the VA. We would pay for the VA to study Mdma-Assisted psychotherapy for PTSD. And it now looks like after 29 years of trying, it might actually be at the Bronx VA with Rachel Yehuda, who's connected to Mount Sinai. And so she has a very good chance of getting a study that we're actually also still funding that would be comparing Mdma-assisted psychotherapy 2 sessions versus 3 sessions.
And I definitely want to talk about the hurdles that you have to go through to get to these steps, because these drugs historically are looked at least over the last couple of decades, as bad drugs. They cause bad issues. But following the breadcrumbs, how do you decide as researchers, as investigators, to say, this drug that has had abuse in the past and abusive potential in the past might do some good? How do you look at that and say, I want to start looking at ketamine, I want to start looking at marijuana, I want to start looking at psilocybin? How do you start doing that?
Well, for us, we look at the underground use of these drugs. I mean, MDMA, also known as ecstasy, was a therapy drug, quietly though, from the middle 70s to the early 80s, and it escaped from that and became a party drug under the name of ecstasy. And so we were very aware. I first was exposed to MDMA in 1982, and the first PTSD patient I ever worked with was in 1984. And when MDMA was criminalized in 85, all the therapeutic use was criminalized, all the recreational use was criminalized. So in 86 is when I started MAPS as a nonprofit pharmaceutical company. So there's an enormous amount of anecdotal information from people that are using these drugs outside of medical context that are clues for use for medicine.
In our case, it was a little different. I think there are different paths to get to the final outcome. In our case, we were studying what's called the monoamine hypothesis of depression, and that's the role of norepinephrine and serotonin in depression. That's the basis of drugs like Paxil and Prozac and so forth. And we found over a couple of decades that hypothesis had major limitations, that too many patients were not getting better from those drugs. And so we felt we needed to develop another hypothesis. And it's somewhat of a long story, but we felt that glutamate, another neurotransmitter, had to be involved. So we were looking for what drugs could affect glutamate and treat depression, and that was ketamine. And so that's why we first tried ketamine in depression.
So it's kind of a different approach of saying, here's the response we're looking for. This is the drug that creates that response. Let's go look at that drug and see if it works. Marijuana, that's probably the classic one that everybody thinks about. Up until recently, it's been illegal, so research has been very, very hard to come by.
Yeah, but so I kind of feel like I'm the merging of this. We've got kind of both a top-down and a bottom-up approach when it comes to cannabis. I mean, we've got years of preclinical data in animals looking at these potential signals, which I can talk about in a second. But we also have then years of folks using cannabis to treat everything, as I said before, everything from warts to Alzheimer's. And so we actually do have a lot of at least prospective longitudinal data where we just follow folks who are using cannabinoids to self-treat different conditions. It's tough because there's such a strong belief in these drugs that sometimes it's tough to disentangle placebo from actual signal. But when you have both folks telling you this is helping me for this condition and animal models of the condition suggesting therapeutic potential, why wouldn't we study it? So for my own work, what got me really interested in PTSD in particular was I had a background where I was studying in graduate school more recreational use of cannabis. How do we differentiate problematic from non-problematic use? If we are going to legalize, what do we actually, how do we determine who's going to be at risk? And then I started training as a therapist because it's the final year of your PhD in clinical psychology. You go and you just do a year of therapy. And I specialized in treatment of PTSD. And my veterans were all using cannabis, different types of cannabis to self-treat their PTSD symptoms. So digging in the literature, everybody around me is going, this is terrible, we have to tell them to stop, this is going to interfere in their treatment. And when you actually looked at animal models, there was this really cool finding where low doses of THC, high doses of CBD showed a signal for something called extinction learning, which if you go back to Pavlov's dog from Psych 101, you'll know that you remember that you can train somebody to associate, the sound of the bell with salivating. It's the same thing with a lot of disorders like PTSD. You learn to associate trauma and fear with things around you, things that remind you of the trauma. And when you're going to get better from a disorder like PTSD, you have to learn to disentangle and break that association. Well, if you've got a disorder like PTSD, the pathology of that is you're not able to disentangle and break those associations. And what was very cool is the Anemone models were suggesting that low-dose THC, high-dose CBD could potentially speed up how quickly you learn to break those associations. Now, that is completely novel because if you look at most treatments for PTSD, they are acute treatments, meaning you give that to somebody and they have, maybe you give them an SSRI and you hope that it, down the road helps their mood generally, or you'll give them something like a benzodiazepine, which please don't prescribe folks with PTSD benzodiazepines, but you'll get an acute reaction where you'll reduce the anxiety response, but you don't see long-term change in function. You're not actually changing pathology of the disorder. And there was indication that cannabinoids could do that.
Yeah, well, I'll say one of the things that makes it really hard to do research with marijuana is that in the United States, since 1968, there's been a federal government monopoly on the supply of marijuana that can be used in research. It's the only supply that's federally legal. And for the longest time, if you wanted to study the harms of it, they'd be happy to give it to you. But if you wanted to look at the benefits, it would be very difficult or impossible to get. And at the same time, their marijuana can only be used for research. It cannot be used for commercial sales. And in phase 3 research, which is what we're at with MDMA, you have to use the exact same drug that you want to market. So as long as this monopoly exists, there's been no way to actually do commercial development with the marijuana plant. And now we're hoping through either importation from Canada or Israel or elsewhere, or a very good chance near the end of this year or early next year we'll break this monopoly and get more federal licenses.
And all these drugs we're talking about, ketamine, psilocybin, CBD, marijuana, they all have a lot of claims out there as to what they can do, which is essentially curing everything, like we've talked about, from acne to Alzheimer's to cancer, you name it. Are the claims outpacing the science? And is the science not there yet? And is there a reason the science isn't there yet?
There needs to be controlled studies. In the case of ketamine, originally there were placebo-controlled studies, which is kind of the standard. And then for ketamine to be approved, it had to be compared to a existing antidepressant drug. So it's a pretty high bar, at least in terms of ketamine, to get approved because it's treatment-resistant depression. But you do have to have some comparator because, as Mallory mentioned, there's a lot of expectation out there, which results in a placebo response and not a real drug response. So you do need controlled studies to prove efficacy.
Yeah, and a big question is who are paying for these studies. So as of September 2018, there was 1,036,000 veterans receiving disability payments from the VA for PTSD and about 500,000 others for other mental health disorders. But the VA has not been willing to spend a penny on MDMA research, but they spend roughly $20 billion a year on disability payments. So it's also the case that with psychedelics, less so for ketamine, but I even think ketamine would be more effective if it was combined with psychotherapy of some sort, instead of just being seen as a pharmacological intervention. But pharmaceutical companies don't understand anything about psychotherapy, and all of the drugs that we've been talking about are in the public domain, and that also limits for-profit investors from getting involved, which is why we're doing nonprofit drug development through donations.
I mean, Rick is right about ketamine, and I would assume it's true for marijuana. That, say with ketamine, it's used in treatment-resistant depression. So these are patients that have been depressed for 20, even 30 years, and then they start feeling better. But their life has been affected by the depression, and they need therapy, at the same time. It's like rehabilitation, especially in veterans, right?
Well, and especially like the mechanisms I'm talking about, it's really, the mechanism is a capitulation of the therapeutic process. It's, when you come in for therapy for PTSD, there's specific mechanisms we're trying to boost, depending on which therapy you're using. Extinction learning is a big one. Another one is changing the way you're thinking about your trauma, so kind of a cognitive shift. And when somebody is so stuck in their belief, how do you get somebody to change? If you think of when you've ever sat and had a conversation with somebody and tried to change the way they believe about something, you can get into this back and forth, and it's incredibly difficult to do. This is the challenge of therapy. So getting somebody to literally convince themselves that the rape was not my fault, that is an incredibly difficult thing to do. And so to have a tool that could potentially change the way somebody's responding to thinking about their trauma, I mean, that's just not the type of drugs we're talking about that we've ever developed before. Huge potential. But again, I agree with you. When I tried to get funding for the study I'm running now, prior to going to, at the time we thought, oh, this isn't going to be something that'll ever be funded, by VA. So I went to private pharmaceutical companies developing cannabinoid drugs and said, are you interested? And they said, not with therapy. Drug alone, but not with therapy. So it's something that kind of has to happen in the public space, which is difficult.
I think the really important thing to note, though, is that the FDA, the Division of Psychiatry Products at FDA, is our main ally in this whole, since 1992. And it's not because they're pro-psychedelics or pro-ketamine or cannabis, they're pro-science over drug war ideology. And so there's been basically an open door since 1992 to develop psychedelics and marijuana into prescription medicines. And it's just been a difficult question about gathering the funding, doing the preliminary studies. But at this point, there's really no regulatory obstacles towards developing any of these drugs other than cannabis or marijuana because of this monopoly.
And these drugs, all of them, without a doubt, there are critics behind these drugs. There are critics who say that it should not be used this way. We're basically bringing these drugs into the forefront for whatever reasons. Is that one of the things you guys are having to deal with when you're looking at these new medicines, these old medicines?
We had to deal with that for the last 25, 30 years. But once we were finally able to get initial pilot studies where we could show that the benefits outweighed the risks, it's been very difficult for critics to say no. And what they're basically saying now is, and there's not that many of them, is that it sends the wrong message to young people, that we need to tell young people that these drugs are all bad, they should never do them, and when you start having these studies that demonstrate benefits under highly controlled circumstances, the concern is the message gets out and it's a wrong message. So I'd say that's the last viable kind of criticism about that, and I say it's on our part, we have to really be careful not to overstate the results, but also to say that it's not about the drug, it's the drug therapy combination. So if people get these on their own, they shouldn't expect the same kind of results.
We had a lot of obstacles to study ketamine. To get approval from our Human Investigations Committee, we had to go through a lot of hoops because of the issues around Special K. So I assume that's true, that both of you have, that to get through IRBs, it's a task. And whenever you want to do research that is truly transformative, you're going against the grain. And so I've been studying this because we're working on a paper on how we made the discovery. And it turns out there are 3 phases. Phase 1 is people think you're crazy. Like why would you study ketamine or any of these other drugs? That's phase 1. You have a lot of obstacles. Phase 2 is what you're doing may be true, but it's irrelevant. And phase 3, well, maybe they thought of it. So we're in different phases here, right? But that's what you face when you're going to make a truly transformative finding that will affect many people.
Yeah, but back from 2000 to 2004, when we were trying to get approval for our first FDA study with Mdma-Assisted therapy for PTSD, we actually had to go through 7 different IRBs. They all said no. And then we started our own IRB. And I thought, well, that's one way around it. But I said, before we'll actually launch that, I'm going to go out there and try to see if there's one more IRB that we can try. And there's a list of these IRBs for people that are not at institutions. And one of them was called Copernicus IRB. And I thought if anybody is sympathetic to political religious pressures on science, it would be Copernicus IRB. And they ended up approving the study.
So it's often said that there's no such thing as bad drugs, there's no such thing as good drugs, there's just the way the drugs are used. And the examples I can give you is dextromethorphan, that's a cough medicine. And people who abuse DM, which is when you go to the store, you can just get any cough medicine with DM in it, it's called robotripping. They can abuse Phenergan, they can abuse Ritalin, there's all these drugs they can abuse because they're good drugs used in a bad way. And this certainly falls in the category of what we used to think of as bad drugs, being used in a good way. Ketamine being a perfect example. You were telling me earlier, it was used in Vietnam for anesthesia. It was the most used drug for anesthesia in Vietnam. Then we lost favor with it. How do we end up losing favor with these drugs?
Right. So actually, it was used for anesthesia, but it was also used for analgesia, which means,
Analgesia.
in lower doses, it was used as a pain medicine.
Right.
And given that it's not an opiate compound, and it works very effectively, it was a really good compound, and it works fast. But then when you had the issues of abuse, people pulled back too far, and we had to push it forward again.
So it's that abuse potential that causes issues.
Yeah.
Which I find fascinating because, I mean, I think with a lot of these, it's the intoxicating nature that really scares folks. Like, even a few days ago, we did a talk on CBD, and as soon as we mentioned that hemp-derived CBD contains some THC, there was like an audible gasp. Like, this is this horrible thing. You know, we're talking about this tiny little bit of THC. And I find that interesting because a lot of our, like, especially the classic hallucinogens, LSD, psilocybin, even to a degree marijuana, though, you know, cannabis does have some abuse liability. But a lot of the classic psychedelics don't. You don't see animals self-administering LSD. You don't say, nobody's jonesing for some acid. Like, it's just fascinating.
Yeah, because it really wasn't about the abuse potential that the psychedelics got criminalized. It was about the 60s, and it was about psychedelics being used by the counterculture, being used by people who were protesting the Vietnam War. John Lennon and the Beatles were using LSD, and they were anti-war. And so a few years after Nixon criminalized all these drugs and declared the war on drugs in 1970, there was an interview with John Ehrlichman, who was his domestic policy advisor. And he said Nixon's two main enemies were the civil rights activists and the hippies. And he said, we can't criminalize what they say, but we can criminalize the drugs they're using. And if we can do that, then we can bust up their meetings, arrest their leaders. And so I think that was the real impetus. The cover story was, oh yeah, it's about abuse. But it really was about fears of cultural turmoil. And I think those fears have diminished now because so many people who have had experiences with psychedelics didn't drop out, didn't go live on a commune, made important contributions to society. And so it's not about these drugs being connected to counterculture values or anything. Now we're really trying to mainstream them. There is abuse potential, and that's a big concern, but we need to educate people honestly, because when we do these exaggerated harm reduction public education campaigns that people know are not true, then they don't know what to believe, and then it's even more dangerous because they'll try things that maybe they shouldn't.
I think that's a really important point too, that like, yes, these drugs aren't all bad, but they also aren't perfect, like any medication. And especially with cannabis, there is actually real concerns. I think it's one of the biggest problems with the fact that application is just so far outrun our scientific understanding is that everybody's using them. And I hear this rhetoric a lot of like, it's not dangerous, cannabis use disorder isn't a real thing, you can't become addicted, or it's totally perfectly healthy. Whereas there are certain folks who should not use THC. If you've got a family history of schizophrenia or any kind of psychotic disorder, it's a perfect example. Probably best not to use high THC products. But we kind of can't get that message out when we're in this like phase where there's like a political battle around the medication.
And it's one of the uphill battles that you guys face when you're doing your research and investigation, the fact that a lot of times, again, the claims outpace the science, that people start looking at these things and saying a little bit, okay, you've opened the door a little bit, oh my gosh, this is the greatest thing ever, let's try and use it for all sorts of things, it's going to cure everything. And you guys have to try and fight that to a certain extent.
So we did have that with ketamine. So when we published the first paper in 2000 and then another paper came out in 2006, after that, a lot of practitioners started using ketamine off-label. Of course, ketamine is available as an anesthetic agent. And literally hundreds of ketamine clinics started to be formed around the country and even around the world. And they weren't modulated in terms of what they could do. So ketamine was being tried not only for depression and somewhat for PTSD, although it might work in PTSD, but for so many other things that there really wasn't good information yet. So you got to be careful. You got to go based on what you've learned in a controlled way.
That never happens with cannabis.
Well, on the other hand, when we're talking about drugs to help psychotherapy,
Right.
when you think about the range of things that psychotherapy is for, so let's say, Mallory, you find out that CBD helps prolonged exposure in PTSD. Well, what about all sorts of other issues that people have with that they go to
extinction
psychotherapy
learning
for?
underlies,
So
yep.
I think are a large number of applications that we will eventually be demonstrating scientifically.
But, I mean, and this is kind of my soapbox that I know you've heard a lot from me, Rick, is the thing I worry about with when everybody thinks this is the panacea is that it makes our trials really difficult to conduct because the gold standard is a placebo-controlled trial. It means that the active drug needs to outperform placebo. And how do you outperform something when placebo can literally like cure something? Like the other day, they were even saying in the Epidiolex trials, there were folks on placebo, children with incurable epilepsy who were not having seizures anymore on placebo. So how do you outperform something when there's such a strong belief that people are all, I mean, getting better on placebo? And we do see that. Actually, if you look at clinical trials on cannabis, pain is a great example of this. You actually see a bigger effect size in placebo for these pain trials than you would in other trials for other medications of the active drug. So people are responding as if as better than they would on any other trial in the placebo
You still
condition.
need to beat placebo.
Yeah, but how do you do it?
Placebo can be a very good drug.
Yeah.
You know,
Right.
it's safe.
Yeah.
You know,
Yeah.
you know, expectation is important. The brain changes when you think something is going to work. Your immune system, you know, changes and so forth. But the bottom line is, you need to win. You need to win over placebo.
Right. So
Or an
I'm
active
like, I kind of
comparator.
want to like temper everybody's expectations just so they don't come in being like, I mean, I have folks who show up for my trials and they're like, I'm here to prove that this works. And I'm like, oh, next. Because that's a danger, you know, that's a dangerous game to play. I mean, for one, there are those folks who are just, they're there to, you know, they're going to say that they got 100% cured. But when we have people who are going, you know, on their PTSD caps from full to zero in placebo, you would never see that with any other drug trial. It just makes our job really difficult. I worry about type 2 error.
Yeah, we just finished the first study ever of cannabis for PTSD, smoked 4 different kinds. It was thanks to everybody here who's from Colorado, because it was $2.1 million we got from the state of Colorado from the marijuana taxes. But one of the people that was in our study was had severe chronic treatment-resistant PTSD. He was on opiates. He was able to stop the opiates. He was able to get over his PTSD, and he actually became a public spokesperson talking to the media about how effective marijuana was for his PTSD. When the study was over and we uncovered the blind, he had the placebo. It was extremely embarrassing.
You know, it's interesting because CBD is probably one of the poster childs of you know, kind of this phenomenon of these things taking off that before we used to think were bad, and all of a sudden it works for everything. If you look at CBD, it's amazing the claims they have out there. I often call CBD, and a lot of people do, that it's the avocado toast of 2019. You know, it's the thing you can get it for anything, anywhere. Is that one of the difficult issues, that there's so many expectations, and when these expectations fall away, all of a sudden this drug's going to lose favor in the populace, in the government, and these people that you need in order to be able to do the research?
I mean, yes, but I think in some ways I'm waiting for that to happen a little bit because, again, you've got such a strong belief on it working for everything. It means that there's not a lot for me to account for between groups if everybody gets better. If everybody's cured, there's no way for me to look at differences. And so part of me almost wants to am I allowed to just call it a random drug name? Do I have to call it CBD? Spoiler, IRBs will not let you do that. I have to tell people what they're getting. But I mean, that would actually be nice. It's actually working against us a little bit that people are so gung-ho.
Yeah.
But the placebo effect tends to be short-lived. So you get the expectation, it works for a while, but then the disease comes back, and you see the placebo effect, going away.
Long-term.
So you got to do longer-term studies to separate from placebo.
Yeah, what's complicated for us too is that what we say is it's Mdma-assisted psychotherapy. So the placebo group actually gets psychotherapy, but with inactive drug. And so we actually have to compare the group that gets psychotherapy without MDMA with the group that gets psychotherapy with MDMA. And so it's not a true placebo that's getting no treatment. The psychotherapy is actually quite effective, but nevertheless, the MDMA is so remarkable at its ability to reduce people's fearful memories from their trauma, and it helps them process it in a way that, at least in the phase 2 studies, we've been very easy to get statistically significant differences. And we won't know how that is for phase 3 for a couple of years, but we're very hopeful.
When something happens like Denver decriminalizing magic mushrooms, does that help or does that hurt your research?
Well, the people from who are doing psilocybin, that was, Denver said psilocybin was the lowest enforcement priority, and Oakland just decriminalized plant psychedelics as well. The people who are doing a lot of the work with the psilocybin, particularly at Johns Hopkins, at NYU, were freaked out by that because they thought that once the science is being used for drug policy reform kind of things, they were worried that the FDA would crack down. But that's not going to happen. And actually, I think that it's helpful because the more that the public is sort of moving in this direction, the more we need science to find out what's really going on. So I think from the regulatory perspective, these efforts are helpful to us. But the thing that's unhelpful is that they make all these incredible claims about all these drugs, and that's, destroys a lot of credibility.
When they make these claims, again, they're over there spurious, there's a lot of different ones. Does that make you guys just run even faster to try and catch up the science to what the claims are?
Well, we're already running as fast as we can.
So you can't really run
But I
much
would
faster,
say
right?
that if we had more donations, we
Right.
could run even faster. I've heard about philanthropy here at Aspen Institute and all. So at least for us, I recently turned down a $50 million offer of an investment because I think that changes everything. I mean, really, nonprofit drug development is about really trying to empower the patients, trying to do the most healing, not trying to charge large sums of money for the drug. And so I just think at this stage that we're at, if we start taking investor money, it would change everything that we're doing. Plus, we have so many people that are donating their time or working for less than their normal fees, that if we start taking investments, then our cost structure will change as well. But otherwise, we are running as fast as we can.
Phase 3 studies cost tens or even hundreds of millions of dollars to get approval from the FDA. So you generally need a partner.
Yeah, our phase 3 study in total for the FDA is going to be about $35 million. And we've raised all of that from donations, including from Rebecca Mercer, the Koch family, George Soros, and a whole range of bipartisan support. And it'll cost about $10 million more to bring it to Europe. But then there's all sorts of other indications for MDMA. So what we've actually done is thought about trying to earn some money from the sale of MDMA, but we can't keep that inside the nonprofit. So I think the profit motive is what warps a lot of American healthcare. So we've created the MAPS Public Benefit Corporation, which is a modification of capitalism where you maximize public benefit, not profit. And so that's the entity that we're going to use to do the research, to sell MDMA, and it's 100% owned by the nonprofit. So whatever profits we do make will go to support other research.
But at the same time, the business models can certainly help get that research going, which is important as well.
Yeah.
The tough thing for cannabis is we're in this weird space where there are a lot of private companies that are racing to try to find efficacy for their products for different conditions, which is great, but the problem is that when else do you see tons of drug companies all developing the exact same drug at the same time and trying to beat each other and who gets it to market faster? That doesn't normally happen. And so what ends up happening is there's a lot of corners being cut, where you're not seeing a lot of phase 1 data, dose response, PK, to actually be really precise about what are we actually going to develop, what's the best possible strain or type of cannabis that we're going to administer for different conditions. Cannabis in general is actually a pretty, not the best pharmaceutical. I feel bad saying that, but don't get me wrong. But in terms of bioavailability, it's actually, you don't get very much in your blood, you don't get all that much going to your brain. And so I think we're going to see a lot of movement in this space of people trying to develop these kind of new precursors to different types of cannabinoids. You're going to see permeation enhancers, all kinds of things. And I don't know, I hope people are going to slow down and take a second, take a breath, work together. But that's only going to happen if it exists in the public space.
We haven't mentioned NIH.
Right.
And NIH is the National Institute of Health. And in my own opinion, it should be putting a lot more money into therapeutics. And it doesn't. And so some of the compounds that we're talking about here should be funded by NIH to do the well-controlled studies and so forth. And with ketamine, the NIH did not put much money into ketamine. In fact, some of the early studies, the study sections rejected the studies because the study sections tend to be risk averse. That they want you to have done the study already so you can get funded. But if you talk about something that is really novel and transformative, you don't get the score you need to be funded.
Is that catch-22? I'd like to go ahead and open it up for questions here, please. Keep your questions brief so we can get as many as possible. She's got a microphone. Use the microphone because they're recording this.
I'm curious if you have come across any anecdotal data for concurrent use of psychedelics with accelerated resolution therapy in PTSD?
Accelerated resolution therapy?
Yeah, have you heard of that? It's like the rapid lateral eye movement.
Oh,
and like,
EMDR.
Okay, yeah.
Okay. Well, no, because we can only study one intervention at a time. But there's a lot of people who have gone through EMDR that have, it works in milder forms of PTSD, but more severe, not as well. So we have a bunch of people in our studies who have failed on EMDR. But I think it might be more effective with CBD or combined with MDMA one day. I mean, we're actually funding leading VA researchers to combine MDMA with prolonged exposure, cognitive processing therapy, and cognitive behavioral therapy as well, because we don't necessarily think our method is the best. We'd like to explore others, but I think once you do MDMA therapy, at least in our model, we don't combine it formally with anything else. And so the question is, again, who would pay for that research?
Next question.
Hi, I'm wondering about the effect of the opioid epidemic on the conversation and the search for a healthier pain management solution.
I'm happy to take it.
Yeah,
So
cannabis.
especially in the cannabis space, I think this is a big question that you hear a lot. In fact, I feel like it's kind of the number one piece of rhetoric you hear when you talk about movements towards legalization. So I kind of don't want to say that this isn't a good thing, because I think that it's actually, the fact that this is such a strong talking point, I think really motivates people. But so far, the data hasn't been, we don't have a ton of data on CBD, and that one is the one that I think could be the most promising in terms of it does not have an abuse potential. You do not see craving or withdrawal or tolerance to CBD. So if you're looking for a really safe alternative, if that did have analgesic effects, that would be amazing. But again, we don't have any studies on it. We don't have any human administration studies with CBD. The most work that's been done in the cannabis space in terms of having analgesic effects has been THC, and that's low-dose THC. But even those studies, the effect sizes actually haven't been as good as non-opioid even medications. So there are currently better ones. That being said, there's a lot of really interesting work that's going on right now, looking at low-dose THC in combination with opioids, which I think kind of freaks people out. But the idea being here that can you actually do a very low dose of the opioid and get a higher amount of the analgesic effect, which is what you see, this interaction, where you see an interaction on the analgesic effect but non-interaction on the abuse liability. So it could potentially be safer. But if you've got somebody who's already developed an opioid use disorder, this isn't necessarily the first thing that I know I would be recommending to anyone if I were, a physician and recommending these drugs. But there has been some data, very new, my colleague Yasmin Hurd has some data that just came out looking at CBD, high CBD, as helping with craving and withdrawal. So helping folks as they actually come off opioids. And I think that could be the biggest potential in this space.
So ketamine is a analgesic. It's a non-opiate analgesic. And it is used by anesthesiologists and other pain doctors as an alternative to opiates for pain. And we know the opiate epidemic is resulting a lot from the use of pain meds. And then people get addicted, from after a medical problem. I think ketamine has been underutilized as an analgesic because, doctors may be concerned about some of the other effects, and that if you use ketamine first for pain, then you might reduce the addiction because you're not using pain meds. And a lot of addiction also results from depression, anxiety, PTSD.
Right.
Ketamine might help there too. And as Rick knows, that it was being used, on the battlefield. And as an example, not getting soldiers addicted by using it on the battlefield, right?
Yeah, definitely. Yeah, and I think the opiate epidemic has just made people more aware of the driving causes for addiction, which in often cases are not just pain meds, but psychological factors like depression and PTSD. So it's increased the interest in trying to find new approaches, particularly approaches that we're talking about, ketamine, MDMA, psilocybin, where they're only administered a few times with psychotherapy. They're not daily drugs. So there's more interest in trying to develop those kind of medications.
Right, that's another key. With ketamine, you don't have to take it every day.
Yeah.
In fact, its use in depression is twice a week to start, and then it can be reduced over time. And the same can be true for pain.
That's a really important point. Same thing with even cannabinoids for like PTSD. We're not talking about reactionary use where you're getting distressed and you quickly, you take some of your vaporizer to calm down. We're talking about this kind of slow dosing so that they get to a steady state, and then actually take them through treatment. So very different than I think when people hear about these drugs, what we're actually suggesting or testing.
Next question here, sir.
Hi there. Is the discussion, it seems that it's about THC and CBD, but what about all the other plant material compounds and terpenes and such? Is that something that the study is actually looking at as well?
If I could get some money to study that, that would be great.
Yeah, when you get the marijuana from the federal government, all they tell you about is THC and CBD. They tell you nothing about what's in it from the other cannabinoids or the terpenes, and then sometimes they're even mixing different strains together to get the same amounts of THC and CBD standardized, so you really don't even know what you're getting. And so it's very difficult to do research using government marijuana for cannabinoids that aren't THC or CBD or the terpenes.
Right, but I mean, a lot of this work is happening more in the private space. So, I do hear about individual companies are obviously looking at some of this, but they're hindered too by what they can administer, in humans. So a lot of this is more happening with animals. And, I don't know, animal models of things like depression, I'm like, how do we know a rat's depressed?
You just ask them. Next question back here.
I'm just wondering, what is the international research saying, or what are international researchers doing? Because I know it's quite repressive here in the US, but there might be some pretty cool stuff going on elsewhere. So what's going on? And maybe a side question, which is any interesting research on mushrooms?
Yeah, well, first off, it's not that repressive here in the US. And in fact, we had a long time international strategy for this. It was repressive from we're starting around 1970, late 60s, when psychedelic research was slowly diminished and then wiped out around the world until around 1990, when it started up again with Rick Strassman getting FDA permission for DMT research, and then this meeting in 1992 at the FDA. So really the international research has followed the US research, not the other way around. And so we have negotiated with the European Medicines Agency about bringing MDMA to Europe, and they're very open to that. And then they'll accept our FDA data. And so what we're finding is that the progress that we're making here in the US ripples all over the world, and there's widespread interest now all over the world in looking at psychedelic research.
Next question.
Dennis, can you address ketamine and adolescent depression? And also, there was an article recently that Ken Davis wrote about marijuana under the age of 24. So can you just talk about the effects on adolescent brains, both therapeutically and recreationally?
Yeah, so what was the first question about depression?
Ketamine, the use of ketamine in the treatment of adolescent depression.
Oh, adolescent. Well, Ken's right over here, so he may want to talk about his op-ed. But it needs to be studied in adolescent depression. There's been a couple of studies in adolescents that have been positive, but there has been concern about giving ketamine in terms of its abuse potential. But I think in controlled ways, in adolescent depression that is treatment resistant, and so the adolescent is in the hospital. They can't get out of the hospital. They can't go to school. They don't have any relationships. They have failed every other standard treatment like the SSRIs. I think those studies should be they should be done. In terms of the effect of marijuana and similar products on the adolescent brain or from kids going on, that's an issue with all drugs that get in the brain, because the brain is not fully developed until you're a young adulthood. And so if you're giving medicine in the brain that is still developing, you got to worry about it, and you got to test it in preclinical models, to see if in those studies the brain is affected by administration. And there's some, I think, clinical data that makes you worry about, having marijuana or similar products, available, and adolescents are using them when they're not supposed to.
Well, and I just came from the College for Problems on Drug Dependence, which had their annual meeting just this last week, and there was a ton of data actually on this. And the biggest kind of differentiation seems to occur if folks are using heavy use in THC, high THC cannabis before age 16. That being said, that data isn't on medicinal use. We don't have that yet because we haven't seen medicinal use in adolescents really yet. We're just kind of seeing that now. So I think that data is going to be the more compelling, and I say that because who is using cannabis heavy daily before age 16? You can think of all of the comorbid factors there, which also are going to be responsible for all kinds of deleterious effects as the child gets older. Alcohol, tobacco, you can almost never disentangle from cannabis use before age 16.
Yeah, the FDA is actually requiring us to do, if we succeed with MDMA-assisted therapy for PTSD in adults, they're requiring us to do work in adolescents from 12 to 17-year-olds. And so we've had to submit a pediatric research protocol already, as it's what's called phase 4 studies. So if post-approval studies that you have to do. If those work, we have to go down to 7 to 11-year-olds with trauma. And so I think for kids like that, depression changes your brain, PTSD changes your brain. So we're trying to talk, it's not like you're going into a group of people that are, healthy and doing fine. We're trying to reverse problems that they've had because of depression or PTSD. And there was recently a study by researchers at Johns Hopkins that gave MDMA to octopuses. And it turns out that octopuses are asocial unless it's mating season. And so there was some question is, what does MDMA do to octopuses? Because apparently, roughly 250 million years ago, humans and octopuses diverged, and they do have serotonin systems. And it turned out that you give MDMA to an octopus, and it wants to hang out with other octopuses, which makes me think it would work in kids. So because octopuses are not verbal, it's pre-verbal, and yet the effect of MDMA on pro-social behavior is demonstrated in animals' preclinical studies.
And just to clarify, it's octopuses, not octopi?
It can be either.
Okay,
actually.
We have time for one more question if there's one out there. You guys have any questions? Great. Well, thank you guys very much for being here and being on the panel, and very important information. I appreciate it.